throat's trying to do something funny, so I hope you can hear me. I'm Debbie Pearson with the Wellness Committee, and we are very, very happy to welcome Dr. Meghpara. I say it kind of right?
That's correct.
Close enough. Dr. Meghpara, who is an expert in hips, and he is going to talk to us about mainly hip replacements, because the statistics of getting a fall and a hip pinned as opposed to being proactive in getting a hip replacement, the data is very skewed positively in hip replacements. So anyone that's on the edge, it's a good thing to consider before you fall and break your hip. So we all know that from the community that we live in. And sorry about the throat. There are a couple things about Dr. Meghpara. He had a long journey over here from across the street at the Grove where he lives. So that was a good thing. You just had to walk on over. And the second thing, which is even better than that, is he is going to be a new dad by Christmas. So I'm going to give it over to him because he has a better voice than I do, I can assure you. And we'll hold the questions till the end if you can. Cell phones off. Thanks.
Thank you. Thank you for that introduction.
Oswaldo can fix anything.
I think can everyone hear me all right?
Yeah.
Perfect. I think we're good here. Yeah. Thank you for that introduction. My name is Dr. Yeah, just to reiterate, Dr. Meghpara, the H is silent. Looks a little bit more intimidating than it really is. But yeah, I'm practicing out from Austin Sports Medicine, which is actually not too far from here, just next to the Heart Hospital, 38th and Lamar. Our group name is called Austin Sports Medicine, but we do see people of all ages. We take care of athletes and the high school kids, but predominant part of our patient population are the elderly population with arthritic joints, whether that's knees, which is probably the most common, hips, shoulders, ankles, anything related to joint degeneration or joint pain, we will see, despite our name being Austin Sports Medicine. So we're a multi-specialty group. My kind of specific practice is tailored towards hip-related issues. I treat everything in and around the hip. This talk is geared towards more so just hip replacements. We did have a brief talk or comment about hip fractures. I don't do hip fractures anymore, but as Debbie said, hip-related issues can lead to falls, which then subsequently can lead to a hip fracture, which is significantly more devastating than just taking care of an arthritic hip. And so it is important to kind of manage and take care of joint-related pain sooner than later. The hospital that I operate out of is St. David's Medical Center. That's the only hospital I go to, which is actually not too far from here. Depending on some insurances, we'll have to go to Seton, but from a Medicare standpoint, we take all of our patients to St. David's, so that's the hospital that we utilize. I'm originally from Chicago, so did all my training in Chicago, and then moved here about a little over 5 years ago. with some training in specialized training in sports medicine, and then I just did a year of training in hip-related issues, and that's kind of what I'm here to discuss. So, in terms of the hip, we'll talk a little bit about joint pain, what it is, why people predominantly have joint pain, treatment options for this. Not everyone needs surgery, and that's typically the last resort. So there are many, many alternatives to treating joint-related issues that do not involve surgery, and that's predominantly what we do for the most part. And then, obviously, if needed, surgery would be the next step. And then we'll talk a little bit about the surgery and kind of the nuances behind surgery. Now, if you notice this, I'm not a consultant for Stryker. Stryker's an orthopedic company that has orthopedic implants, and I only use Stryker-related components because they have a robotic system that allows us to do hip replacements a little bit more accurately. And so one of the things I do with hip replacement surgery is utilize robotics, and I'll kind of go over that a little bit. And then finally, what to expect afterwards, and your recovery process, and what kind of things you can get back to, and maybe some things to avoid. So in terms of pain, it's fairly common. It's almost inevitable as you get older. And joints, I always tell everyone, joints, it's a mechanical part. Just like a car, 20 years after you buy it, it's going to start creaking, rattling, and tires may need replaced, and suspensions may need replacements, and your belts may go. The body is very similar to a car in terms of, there's a lot of moving parts, there's a lot of mechanical aspects to the human body, and one of them is your joints, and all the joints are different too. A shoulder joint, although it's a ball and socket joint, functions much differently than a hip, which is a ball and socket joint, predominantly because we're not walking on our arms. The shoulders are not weight-bearing joints, versus your hip is a weight-bearing joint. Now, hips and knees differ significantly because knees are hinge joints, like a door, versus the hip being a ball and socket, which is much more mobile. And so hip arthritis and knee arthritis are very different and are treated very differently. And interestingly, when it comes to a surgery, hip replacements and knee replacements are fairly different. And studies have shown hip replacement patients do much better, or I shouldn't say much better, but are better quicker with less pain as compared to knee replacements, which do take a little bit longer time to recover from. But yeah, joints are very, very important for movement, activity, exercising, which is even more important as you get older. And if you have joint pain, then you're limited by your joints and can't get around as much, and that can lead to subsequent issues too. So treating joint pain is very, very important. Now, in terms of joint pain specifically, arthritis is the most common reason for why patients have joint-related pain. And arthritis is actually comes in multiple flavors. And so there's multiple forms of arthritis. Rheumatoid arthritis is somewhat common, not the most common reason for arthritis, but it can be pretty prevalent. Rheumatoid arthritis is basically, it's an inflammatory condition where your own cells start attacking the joint. So we call this an autoimmune issue. And that results in just uncontrolled inflammation, and even so much so that it can start eroding joints. And there's very characteristic findings, particularly on x-ray, that distinguish rheumatoid arthritis from other arthritis. One of them is patients with rheumatoid arthritis tend to have issues in both sides, so we call that bilateral arthritis. A lot of times it often affects the hand, smaller digits, the wrists, elbows, and then sometimes hips and knees. The more common and by far the most prevalent form of arthritis is osteoarthritis, and that's what most people will probably come in for. And osteoarthritis, we just call it arthritis, but it's osteoarthritis because it's actually the destruction of the cartilage inside of the joint, typically through wear and tear. And cartilage eventually will wear out, just like a thread on a car tire. The more you use it, the faster you drive, the quicker you stop, the tire will wear out sooner. Similar to a joint, the more if you run, or if you're younger and we're a basketball player or a long distance runner, The more you use the joint, the more likely the cartilage will wear out. And then subsequently, that starts to reduce kind of the cushion inside of the joint, and then eventually that will lead to inflammation, and that's why we call that osteoarthritis. And then rarely, and this is more common in younger patients, is post-traumatic arthritis, when you have a significant injury where, motor vehicle accidents or motorcycle accidents where the hip pops out and breaks at a younger age. You kind of get that fixed, and then 5-10 years later, that joint kind of gets destroyed because of that violent impact. Now, this can also happen in elderly population when you do have, say, a hip fracture that's fixed, not replaced, but fixed, commonly with either pins or screws or a metal rod and screws. And because of the impact from that injury, a few years later after fixing that hip fracture, the hip joint becomes arthritic, and then you get post-traumatic arthritis, which is a whole different topic and treatment plan, which I don't do, but can happen. Now, in terms of treatment for arthritis, there's things simple as just walking aids, which is actually very important. Walking aids, either a walker, 4-prong cane, a single prong cane, can definitely offload the joint that is painful. Whether it's your right hip or right knee, using a cane in the opposite hand can make a big difference. And that's one thing that people often mess up is, say you have pain in your right hip or right knee, and you use the cane on the right side, you're actually putting more force in that joint. So you always want to use your walking aid, if it's a single arm aid, in the opposite side. But that can certainly alleviate pressure and discomfort from that painful hip, and stabilize yourself to hopefully avoid tripping, falling, and potentially causing more damage to that joint. So offloading the joint can be very, very effective. Heat and cold therapy is also very effective, particularly before and after exercise. So if you're kind of feeling like your joint's stiff, or you kind of have some discomfort, and say you want to do something, some exercise or your exercise class, heating beforehand and doing cold therapy afterwards can really help, one, loosen up the joint beforehand, and then afterwards the cold therapy reduces the inflammation. And so we call this contrast therapy, to kind of allow you to do a little bit more activity without significant amount of joint pain. And if there is discomfort afterwards, then the cold therapy can certainly help. And then physical therapy, or just exercising in general, is a good way to help stabilize the joints. And so arthritic joints become obviously painful, and then that reduces, or that causes the muscles that surround the joint to kind of weaken, because you don't use that painful joint as you normally would. And so, in a controlled manner, either with a physical therapist or a trainer or whomever, to kind of work on strengthening the surrounding muscles of the joint, can certainly help reduce pain. Now, sometimes people are stuck in between a rock and a hard place, and I get this a lot, and people will say, I'll say, have you tried any therapy or tried any exercises? And then people will say it hurts to do those exercises, which makes sense, because if you're trying to work the joint that hurts, or trying to work the muscles that are surrounding that painful joint, it may hurt. And that's where we kind of go into medications and potentially injections as a form of, or a way to kind of springboard you into allowing you to do stuff and do physical therapy to kind of take that pain away and then allow you to do more. And anti-inflammatories that common ibuprofen, Advil can certainly help. Tylenol is actually not that good of a anti-inflammatory, or is not an anti-inflammatory, so it won't really help significantly with arthritic pain, although they do have Tylenol arthritis, which is marketed for arthritic pain. It's not as effective as what we call non-steroidal anti-inflammatories, which is Advil, ibuprofen, Aleve, naproxen. Those are the over-the-counter ones. And then there's prescription ones that we typically use, like Celebrex, meloxicam. Those are all anti-inflammatories to reduce the inflammation. Tylenol is more so a pain reducer than an anti-inflammatory, but it can certainly help. At the same time, you don't want to be on these too long term, particularly if you have kidney issues, liver issues, stomach sensitivity. So you don't want to be relying on medications for a chronic period of time, but as needed or once in a while is certainly fine. Another thing we do very often in our office are injections. So steroid injections is the most common way to reduce inflammation. People ask about the gel injection. That's commonly given in the knee, and it's only approved in the knee. So you cannot get gel injections, which is a hyaluronic acid injection into a hip as of now, because it has not been approved by the insurance companies. So steroid injections can work well. And again, you're going to get probably temporary relief, or we use that steroid injection to springboard you into hopefully you doing more, exercising more, which then in turn reduces the pain long term. There's fancier stuff out there now in terms of stem cells and platelet-rich plasma injections, which are very, very expensive. Not definitively proven, can work in certain instances, but not really utilized too often. So there's a lot of different things that we can kind of do to mitigate pain from an arthritic joint. Now, if all that fails, then it may be time for a hip replacement. And one of the more common questions I get is, when is the right time, or when will I know I need a hip replacement? The easiest answer is you'll know when you need something more done, but a lot of the questions I'll ask are, trying to figure out, is this severe enough to warrant a hip replacement? One, we get x-rays and see how the joint looks, and if it's a severely arthritic joint, that's one reason. Now, they always taught us in training, you never treat the x-ray, you always treat the patient. So, the x-ray may look one way, but the patient may be feeling totally different. And so, if the pain is affecting your activities of daily living, is it hard to put your shoes and socks on? Is it hard to get dressed? Are you having a hard time getting into and out of a chair, getting into and out of a car, walking a block or two? We're not even talking 30, 45 minutes, just a block or two. Or this building's quite large, and going from end to end is probably a decent amount of distance, and if that's just painful, that's not ideal, because then you're not going to be able to do much activity, and then that can subsequently result in weight gain and heart issues, and even psychological issues where if you can't kind of do much, then things kind of spiral. Or is the pain preventing you from doing what you want to do? Say you're fairly functional, but you can't exercise anymore, and you've tried everything, or you just can't move around like you normally would. That's another reason maybe to consider joint replacement, or basic functional things like stairs, going across a curve, just basic simple things. If they're very difficult, or if you have to think about doing that because of your joint-related pain, that could be an indication for needing hip replacement. So there's a lot of different factors that go into it, but the best way to kind of summarize it is, if it's affecting your quality of life or it's affecting your activities of daily living, that is a good reason to maybe consider a joint replacement. And specifically, my topic here is a hip replacement. So a hip replacement basically is replacing your hip joint, and we get asked a lot in terms of what gets replaced and how does it get replaced. And so in a hip, a normal hip, you have over here on the left a ball and socket joint with normal cartilage and normal bone. In a diseased hip, in an arthritic hip, the cartilage deteriorates pretty significantly, the bone becomes a little bit irregular, and then the alignment becomes out of position, and the hip does not function like it normally should. And so what we typically get are x-rays when you come in to kind of evaluate the joint. And over here, this is a normal hip, and what we say a normal hip looks like is, for me, I'm looking at the space in between this ball right here and the socket. So this curved dome is the socket, and obviously the ball is right here, and you want to see pretty much equivalent space between the ball and the socket. And you kind of want to see that all throughout the entire joint. Versus over here on the right side, there's absolutely no space. The ball does not look round anymore, it almost looks like a mushroom, so it's starting to flatten out, so it's changing its normal contour. you're getting these big black circles in the bone. Those are called cysts. Basically, are areas where the bone is actually being replaced by fluid because it's under so much pressure due to the lack of cartilage that it's wearing out the bone from within. And then obviously there's no space here, and so we call that bone-on-bone arthritis. So this is the severe, end of arthritis. This is a normal hip, and then in between you've got maybe a little bit of narrowing, which isn't too significant of a deal. That's where the physical therapy or the medications and injections can help. Then you can get some areas where there's no cartilage and some areas that are normal, and that's kind of a gray area in terms of how to go about that. But like I said, certain patients will have much more pain than others, and some will be fine. And I'll see some patients with this X-ray over here that don't have much pain. So it really could be all over the place. But this hip over here would potentially be a good candidate for hip replacement if everything fails. And interestingly, arthritis is the most common cause of disability in adults. The most common cause of pain is back pain, but the most common cause of disability is actually having an arthritic joint. And you can imagine walking on this hip on the right would be extremely painful. And then, if you're not taking your step normally, if you kind of get stuck and fall, that could be a problem. In terms of hip replacement, how it works, so basically, let's see. I had a video of the replacement, but that video wasn't working. So what we do in a hip replacement, it's a little different than a knee replacement. Again, it comes down to the mechanics of the joint. The knee is a hinge joint, so you have two metal components and a piece of plastic. In the hip, the goal is to restore the normal function and normal mechanics of the joint. And so what we do is we take the existing ball and we saw it off. And so that ball portion of the joint is gone, and we have to recreate a new socket as well. So we create a socket in the pelvis to take the place of the old socket, and that is a metal shell essentially. And then we put a piece of plastic, which is this little white insert, inside of the hip socket that kind of takes the place of the cartilage. And so that kind of becomes your new cartilage, and it's just essentially plastic. And then we put a metal stem down this femur, the thigh bone. And what that does is it basically acts like a strut, and it holds the new ball in place to replace the old ball. And now you restore that normal ball and socket joint, and this actually probably will give most people more range of motion and more rotation and more flexion because all that diseased bone is eliminated. And now you're just relying on this metal, plastic, and the new ball, which we use ceramic now. So it's a really good way of restoring the normal function of the joint. And one of the good things about hip replacement compared to a knee replacement is because it's a ball and socket joint, it moves in every plane, meaning you can move the hip up and down, side to side, and rotate around. The knee only goes in one plane. It's just a hinge. You cannot, you can't wiggle your knee around. And so knees are more prone to stiffness. In hips and hip replacements, stiffness is rarely an issue. Now, the first probably 6 weeks, 8 weeks, you're gonna just be stiff because everything is sore and just tight. But once this all heals, typically by about 3 months, that range of motion should not be any different than what it was before, and most likely improved to what it was before, versus knees tend to be stiff for a longer period of time because there's only one way that the knee can go. So this is what a replaced hip looks like. So that's the metal socket that we put into the pelvis, the metal stem that goes down the femur, and then this new ball that kind of sits inside of the socket. So it kind of similarly looks to looks similar to the other side. Obviously, just a little bit more metal than the other hip. So here are the components. I use these components for every single hip that I do, and it's because they are compatible with the robotic system that I use, which I'll talk about in a little bit. But a lot of people ask what these components are made of. The metal socket up top here, it's a combination of different metals. So you have a little bit of titanium, you have a little bit of stainless steel, which is cobalt and chrome. So there's metal going into the body, but these metals are very well tolerated by the body and never see any sort of rejection to these components. There has been issues in the past with metal on metal hips and metal debris. That was a big ordeal with a different company. I think now maybe 20 years ago, but we don't do metal on metal anymore, so that's not an issue. The metal itself is not an issue anymore. And then this plastic, it's a polyethylene liner, which is just a very durable plastic that sits inside of the cup. This metal stem also is the titanium and the stainless steel. Now, one of the things about the stem in an elderly population, so typically we don't use cement to fix any of these components, which is a little bit different than knee replacement. You have to use cement. This white area right here, that's a coating on the component, which allows the bone to grow into the component. And so we don't typically have to use anything to hold the metal in place. Now, in women, particularly over the age of 75, sometimes the canal or the inside of the thigh bone, it thins out because of the bone density, and that canal widens, and that canal is too wide for us to put this component in to sit in a stable position. And so, particularly in women over the age of 75, we have to put cement down the canal. And so that changes the component that we use, but does not change the surgery or the rehab or anything like that. So some people do get cement inside of the hip to hold this metal stem in place, and some don't. It just kind of depends on how your x-rays look. Now, in terms of how to replace the hip, I only do one way of replacing the hip, and it's the anterior approach, meaning we go in from the front of the hip. When I trained in residency, I never did one anterior hip. It was all posterior hip, meaning from the back. And now I only do anterior hip replacements. And one of the reasons I like the anterior hip replacement is we don't cut any muscle or tendon. And so it's a muscle-sparing approach or minimally invasive way of replacing the hip, because we don't have to detach anything off the bone, we don't have to cut through any of the muscle or tendon, and so the recovery tends to be quicker. Now, if you look at the data, and depending on who you ask and their bias, people will say both ways are equivalent. I don't necessarily agree, particularly in the early aspect of the rehab. In the first 3 months, I believe these anterior hip replacements will do better because it's easier to rehab quicker. And so, and the other thing is there's no restrictions. You don't have to worry about how you sleep. You don't need a pillow in between your leg. You don't need a raised toilet seat. You can start walking right away. You can go up the stairs right away. So it allows you to move quicker at an accelerated pace and kind of rehab the hip a little bit better, which mobility after surgery is very important also to help prevent a blood clot. So there's a lot of different benefits to rehabbing the hip quicker, and without cutting any muscle, you can imagine there's probably just going to be less pain. And well, I'll see this from time to time where someone got their hip replaced 10, 15 years ago through the traditional way in the back, and then we do the hip replacement from the front, and they'll notice a difference. Now, a year after surgery, probably there's no difference, but I think the first 3 months make a big difference. Also, going in through the front of the hip, the incision's pretty small. Typically, they're about 8 to 10 centimeters, so not too big of an incision to put all that metal in the hip versus going from the back. It's about probably double the size. Theoretically, there's a less chance of dislocating your hip going in from the front, so that's why you don't have to worry about pillows in between your legs or not crossing your legs early on, because there's a very little chance of dislocation. Like I said, very minimal hip precautions after surgery from an anterior approach, meaning going in from the front. So this is kind of the most of the surgeons I think in Austin are doing the anterior approach. So I don't think that's anything different. There's some doing the robotics. Almost everyone will do robotics with a knee replacement. The hip is a little bit more nuanced. and slowly I think people are going to keep getting into it, but I believe to me it's the best way of doing it because there are significant benefits to a robotic replacement. And for me, one of the things is it reproduces and reliably recreates the normal anatomy that you normally have. And so there's no guesswork in terms of where the component goes or how it should be positioned or what size you need. This is all determined before we even get into the operating room, and this is all planned out, and we know everything beforehand, so we don't have to kind of figure it out at the time of surgery. And the traditional way is, because everyone's anatomy is different, one person's socket size is going to be totally different than someone else's socket size, and if we're doing 3 or 4 in a day, you're going to get all sorts of different sizes. It's just like clothes size or clothes or shoe size or what, everyone's got different sizes. And so the robotic way of doing it allows us to know specifically what is going to match your anatomy. And the way we do that is we get a CT scan of the hip beforehand, and that CT scan gets imported into a software that kind of recreates your pelvis in a model form, and that gets uploaded into a software, and it can kind of figure out and calculate the dimensions of exactly the size of your bone, the angles of your bone, how you normally sit, how you normally stand. And then the coolest thing is during surgery, the robotic device positions the components in exactly the same position that it should go in and it was beforehand. And so it's much more accurate. It takes a lot of the guesswork out of the way. Studies have shown that because of the more accurate placement of the components, people get a sense of their hip feeling more natural, as if they've never had their hip replaced. So that's a benefit. Because we know all the sizes, we preserve a lot more bone, so it's less invasive. We're not removing more bone than you need, which reduces bleeding, which then reduces pain, which improves recovery. So that does make a difference. And then for me, the reason why I like it the most is it's incredibly accurate. It takes the human eye out of it. We can dial it down to the half a degree of accuracy. And so to me, it seems like a no-brainer. And I don't do knee replacements or partial knee replacements, but that aspect of joint replacement surgery has significantly been taken over by robotics. The hips are kind of lagging a little bit. There are a few surgeons here that do it, but I think in my hands, I think it works really well. It's been around for a very long time. These numbers are a little bit outdated, but the Mako is the one that I use. It's been around almost 20 years now. Significant amount of publication and data on it. It's used all over the world now, so it's not just a U.S. thing. I would say about nearly 500,000 cases have been done with this software, so it's not like a very new thing. It's reliable and reproducible and has been around forever, which I think is a very useful tool that we have now. Did have the video of it, but the video wasn't working. This is a knee kind of plan, but it does go over how we would do this for the hip. So we get all these data points beforehand, and we can control this during surgery. So a lot of this can be adjusted at the time of surgery if something doesn't look right, or if you need to fine tune something, we can change things in real time just to make it more accurate. And so this model is created specifically to your hip. This is a knee, but same concept. And then this robotic arm for the knee, it will make all the saw cuts, the bone cuts in the knee, versus traditionally you just do it by hand or use a cutting jig. The robot actually will just cut every single position that it needs to cut, so that it is incredibly accurate. And it's kind of AI-driven technology, and it's been shown that that's just much more accurate than a human making a cut. You can imagine that with carpentry or anything. If you're going to have a robot that cuts a right angle, it's going to be much more precise than a human trying to cut a right angle. And so that's what it does, and then it allows the implants to go in the to me, perfect position. So in terms of recovery, recovery is, it's patient to patient. One of the things that we get a lot is, someone will come in and tell me that, their friend or their neighbor had their hip replacement and they were back golfing in 2 weeks or 3 days. You get these crazy stories sometimes that, kind of are probably a little inaccurate. Or a lot of people forget the bad period in the first week or 2 weeks of the pain, and then only remember everything else afterwards. And then they'll tell their friend, "Yeah, it was nothing. I was back doing everything really quickly." So everyone recovers differently, but in doing an anterior hip replacement, not cutting any muscle, getting moving quickly, the recovery process is actually pretty quick, and it's changed dramatically even for me in the last 10 years. And we were just talking about this where for patients over the age of 70, I'll do them all in the hospital, and we'll keep you overnight. Anyone under the age of 70 with no significant medical issues, we will do it in a surgery center and you go home that day. So that can even be done with joint replacements. But anyone over the age of 70, we'll keep them overnight at St. David's, but most people are out by 11 a.m. the following morning. I do surgeries on Thursdays only at the hospital, and most people are gone by 11 a.m. or 12 p.m. So essentially less than a 23-hour stay in the hospital, and you'll do some physical therapy in the hospital, and then depending on where you're discharged, the first 2 weeks there's really not much to rehab besides walking. All you have to do is just worry about walking for the first 2 weeks, walking and not falling. Those are my 2 rules for 2 weeks after surgery, and then you kind of start some physical therapy and kind of work on the muscles and re-strengthening the muscles and kind of getting back to more functional activity. And typically by 6 weeks, it really doesn't matter how old you are. I've seen this, just recently did one in a 92-year-old, and by 6 weeks they were hiking. And so 6 weeks, most people can go hiking, cycle, swim, use the elliptical, do some gentle strength training. Maybe a little bit sore and stiff at 6 weeks, but you're still able to do a decent amount. And that's not for everyone. It can be give or take. Some people will do that at 4 weeks. Some people will do it at 8 weeks. But about a month and a half, most people are pretty functional. And usually about 3 months is when people are feeling like things are fairly normal. And it takes about maybe a year for you to feel like you never had your hip replaced. It could be sooner though. So the recovery process is actually not that bad. From a joint replacement perspective, like I said, knee replacements can take a lot longer. Shoulder replacements are a little different. Ankle replacements are a little different. And to me, the quickest bounce back are hip replacements. And kind of to put it into context, when we'll do an ACL surgery on a 20-year-old, it takes about 6 months to kind of start doing some dynamic stuff or play pickleball or whatever. I let patients, start playing pickleball at 6 to 8 weeks from a hip replacement. And so, and with a lot, kind of a bigger surgery, but it's just the recovery is fairly quick. Now, the whole point of doing the surgery, like we talked about initially, is to get you back to doing what you want to do and get you back to doing things with less pain. Whether that's walking, cycling, swimming, golfing, dancing, pickleball, most things you can get back to. Now, there are some things that I'm not a big fan of trying to get back into. I don't know if contact sports is something that this population may be getting into, but running and jumping, not ideal. No need to, especially as you get older. You get a lot of questions about skiing. Not a big fan of that either. So anything that can risk falling, or risk you falling or kind of breaking the hip, because you don't want to break your hip, but then you also want to break your replaced hip. But besides kind of these, a little bit more intense activities, you can basically do anything you want, which is quite nice. That's about it for my presentation. Any questions?
understood every word. Okay, I got a question over here.
I'll just ask if you know you have osteoarthritis in a hip, and it doesn't bother you usually, and then it starts this little achy trick, when do you know that you really should think about doing something about that?
The achiness, it kind of depends on how often, how severe that achiness is. But it certainly would warrant at least getting x-rays and just seeing how the joint looks. In that situation, I doubt it's too significant of an arthritic issue, or the joint being severely arthritic. But if it's limiting you, the key with all this, and I think with any joint-related pain, is if it's limiting you from doing what you want to do, or if that achiness stops you from doing something. So say if you normally exercise for 30 minutes, but it starts aching after 10 minutes, routinely and regularly, that's when you want to kind of get that checked out. Or if it starts kind of bothering you with just getting up from a chair, or if you're trying to get out of a car and that's always achy, I think it's worthwhile to get looked at. Now, if it's just intermittent kind of tweaks or just nagging pain, I don't think it's necessarily something that you absolutely need to get checked out. But I think if it starts affecting your activity level or your functional level, then I think it's worthwhile, particularly with X-rays.
Is there an age limit or a health?
Age, that it's a good question. We did one on a 92-year-old, but it's a healthier 92-year-old. So health makes a big difference, especially the older you are, and that's also an anesthesia issue as well. I did not mention that here, but predominantly we don't do general anesthesia anymore, meaning there's no breathing tube put down your throat, there's no breathing machine. We do a spinal anesthesia, and so that basically numbs you from the waist down, but it allows you to breathe on your own. You're sedated with propofol, which is what they use for like a colonoscopy, but you're breathing on your own, so it's a lot safer. The brain gets more oxygen, and you don't have those effects potentially with dementia-related issues with the general anesthesia that is kind of coming more into light. So the anesthesia is not too much of an issue with age because we're not doing the general anesthesia. But now, if you have kidney disease, heart disease, lung disease, or liver issues, that could play into a role in terms of whether or not you may be qualified for surgery. I think as long as you're fairly healthy and active, I don't think age makes too much of a difference. I don't limit it based on age. I look more, if you're older and then with more medical issues, that's a problem. Or older and maybe a little breathing issues and stuff like that. That is maybe a little bit more of a concern. Now, I typically don't make that call. Usually we'll have the medical doctor or primary care doctor clear patients for surgery if they deem it's not safe to have surgery. And there are instances where we will not do a hip replacement because it is an elective surgery. You can elect to do it or not do it, and we can elect to do it or not do it. And fortunately, arthritis, it's not cancer. It's not going to kill you if you don't ultimately treat it. But we want to make sure it's safe for us to treat it. And so, if the medical doctors give the clearance and everything kind of aligns for doing the hip replacement, I'm okay with doing it regardless of age.
Any other?
Will you elaborate a bit more about pinning versus a hip replacement in the event of a fall or even a car accident, and who makes that decision? What should we be asking about?
It's a good question. We were talking about this earlier, actually. So yeah, God forbid you do have an injury to the hip. That all is determined based on the injury itself, and so all hip fractures are not created equally. There are multiple different types of hip fractures, and it's based on the location of the injury. Now I can quickly show show you. So here's the ball and socket on a normal hip. So you can fracture the hip right across here, which we call the neck. If the bones don't move, then you'll get what we call a hip pinning, where you put screws through the bone, as long as the bones are in place. Now, if you have this fracture right here, and that whole thing topples off, like the ice cream falling off a cone, those patients are the ones that get a hip replacement. So it depends on how it's broken and how significantly it's broken. Now, there's another form of fracture we call intertrochanteric fracture. It goes from this pointy area all the way down here, and those need the metal rod that goes all the way down the femur and then a big screw that goes into the head. Those cannot get hip replacements. And those are the ones that we tend to see get post-traumatic arthritis, because you can't do anything about the ball. You just have to put a metal screw in there and tend to see that get arthritic. So each different fracture is different, are treated totally differently. And so who makes that call? I mean, you probably end up in the emergency room, and they do x-rays and CT scans, and then whoever the orthopedic surgeon is on call will make that determination. But it's pretty straightforward, when you've been doing it for a very, very long time. So it just depends on where and the severity of the injury.
What limitations are there with respect to knee replacements and hip replacements regarding strength training?
Afterwards?
Yes, well, yes, of course, afterwards. What can you do and what are you advised not to do? Strength training.
For a hip replacement standpoint, I don't really have any limitations. I wouldn't recommend starting strength training until 6 weeks after surgery. But at 6 weeks, you can do squats, you can do lunges, you can do any machine you want, leg press, leg extension, you can do Pilates, you can do yoga, you can cycle, you can basically do anything. To answer your question, I just would not run or jump. So anything that involves like jumping on a box, anything that causes a lot of impact for the joint, I would not do in terms of strength training, which I would not recommend anyways. But there are really no limitations in terms of what you can and can't do to build that muscle back up. Because that's the whole point of getting the replacement in the first place, is to strength train and get stronger. And so I don't have too many limitations, as long as you just keep it within the confines of comfort.
What's your knee replacement?
I don't do knee replacements, but when I used to still know, it's the same concept. Knees, you definitely don't want to be running or jumping on it, but knees, it's even more important to work on strengthening your quadricep and trying to even do more than you maybe were doing 5 years prior to the surgery to regain that strength. So you definitely want to work on the quads and the hamstrings for your knee after a knee replacement. And again, really no significant limitations. I don't think anyone really imposes too much restriction on that. But I wouldn't start squatting 300 pounds, but you can squat, body weight or little dumbbells to work the muscles, but nothing too crazy in terms of weight. But activity-wise, no restrictions.
Are there other questions?
What actually happens when you say someone fell and broke their hip? That would depend on the impact, what actually happens.
What do you mean in terms of the fall itself?
Well, what happens in the hip when someone falls and breaks their hip?
Well, it depends on how you land and where you fell. So falling on the carpet is going to be different than falling on the hardwood floor versus falling on a cement surface. And it's also how you fall. Typically, you're either going to fall right on your butt, and that is actually not a bad way to fall. Because if you do break something in the back of the pelvis, it actually usually doesn't require surgery. So hip fractures are different than pelvic fractures, and so the pelvis is totally different. So you got this big ring right here, that's the pelvis. And so if you fall straight on your butt, you're gonna break the bone down here, and that never requires surgery. Sometimes people break the bottom of their tailbone, which does not require surgery. When you fall on your side and land on the side of your hip, that's where things can really break apart in your hip joint itself. And that, there's no rhyme or reason. No one's really figured out why certain fractures occur in certain falls. It depends on your bone quality. So some people may fall and be fine. And some people may just fall out of a chair and the whole thing shatters. And it just depends on bone density and bone quality. But in terms of how it breaks when you fall, it's almost random. If you were to fall on the side of your hip, there's no way of determining that. So if you're gonna fall, one, I would not recommend falling, but falling on the back side is helpful because it also is a little bit more cushioned with the muscle. When you fall on the side, there's no, you can feel your bone right there. That impact is what shatters the hip.
I had a pelvic fracture with three cracks and bone seal.
Yeah, yeah. It takes a while, and it's not comfortable, but at least you don't need surgery.
Right. And doesn't sometimes the bone break and then the person falls because of
Maybe, unless the bone is incredibly weak, but it's probably more like an arthritic joint, and the joint catches, and they feel like it broke then, but it's just maybe some arthritis, and then because the bone's really not gonna just break standing. It needs impact, for the most part.
Okay, we're gonna take our last question.
I don't know the technical language for this. But sometimes when you're walking along and you're older, a knee will give out. You don't fall, and then it's fine forever until the next time. What happens when a knee gives out? And what happens, does a hip ever give out?
Yeah, both can give out, and it's a good question, interesting question. I think in the older population, when the joint gives out, it's a lot different than like in a college kid when the joint may give out, because that could be like a ligament or a stability issue. In the older population, especially with knees and hips, when the knee gives out, it's actually most likely due to some arthritis in the joint. And the reason why is the cartilage in the joint is the cushion or buffer. It allows the joint to move smoothly and freely. And if there's areas where there's missing cartilage, and the more severe the arthritis is, the more cartilage is missing. But when you move, or if you twist a sudden way, or if you rotate a sudden way, and the knee or the hip catches, or if it feels like it grabs, and then you kind of go down a little bit, it's typically when the surfaces of the bone where the missing cartilage come into contact with one another, it's an uneven surface. Instead of being a smooth surface where it just kind of glides, if there's divots or potholes in the cartilage, and those two come into contact with one another, it's not a smooth motion anymore, and then the knee almost, or the joint, the knee or the hip almost feels like it's popping out or moving out of place or shifting, which is that giving out sensation, but it's actually just the cartilage ends that are abnormal coming into contact with one another, and then you feel like the joint or something gives out, but it's just that lack of cartilage. So that's typically a sign that the joint may be arthritic.
Thank you so much.
You're welcome.
Let's give it a nice warm applause.
Thank you. It's a little late, but really appreciate it.